So today's talk will really be divided into kind of two umbrellas. The first will just be an overview of cancer and cancer epidemiology. I know you got some of that from Dr. Waterbour last week, so hopefully this will be consistent with what you've already learned. We'll talk about cancer mortality and incidence, and I'll also interweave some disparities data into that. And then we'll kind of shift gears and talk about UAB's effort to address cancer disparities, particularly in our region. So just to make sure we're all kind of on the same playing field and know what we mean when we talk about disparities, I think of kind of a simple definition of disparities as differences or unequal burden or unnecessary morbidity and mortality. National Cancer Institute has a much more eloquent definition, which is shown here for you. Adverse differences in cancer incidence, cancer prevalence, cancer death, and cancer survivorship, and burden of cancer or related health conditions that exist among specific population groups in the United States. So basically differences in the cancer experience across the spectrum by group. So a little bit of data, a little cancer epi. Here we have a slide illustrating estimated cancer deaths in the US in 2013. And this is stratified by sex and also categorized by cancer type. So as you can see from this slide, there were a greater number of men who died from cancer than women. And the top 3 cancer types related to death in men were lung cancer, prostate cancer, and colorectal cancer. And among women, the top 3 were lung, breast, and colorectal cancer. So this graph just kind of indicates or illustrates the trend of cancer death rates by sex from 1975 to 2009. And as you can see, consistent with the slide that you saw before, there's higher death rates among men compared to women. Men are in the red line, women are in the gray line. Things have been relatively flat, although we do see a nice trend downward in cancer death rates, probably starting in the mid to late 90s. So first we'll focus on cancer death rates among men. And as you can see, historically there was this huge spike in lung cancer among men that kind of started late 40s, early 50s, and didn't really reverse until the mid 90s or so. This is really correlated with the emergence of tobacco use among men. And as you can see, in the earlier decades of the 1900s, lung cancer death just grew exponentially. Then we learned that tobacco is absolutely a carcinogen. Smoking is not good for our health. And so there were some health education and health promotion efforts behind that. It looks like, based on the trend of the data, those things kind of work to help reduce smoking rates. And as you can see, later on, death rates have started to decline among men. Now, in looking at cancer death rates among women, we have some of the top cancers for women shown on this graph. Again, we see this upward trend for lung cancer, and it's not quite as dramatic. It doesn't completely mirror what we see in men, but part of this is just because the uptake of tobacco use among women happened a little bit later, and so then the smoking and tobacco prevention efforts took a little bit longer to be adopted. But fortunately, that line for lung cancer deaths among women seems to have flattened out and hopefully is trending downwards a little bit now. This graph shows us cancer death rates by race and ethnicity from 2005 through 2009. So the first thing I'd like to point out is that within each racial ethnic category, you can see that men have higher death rates of cancer. So again, that's consistent with all of the previous slides that we've seen. But when we look across racial ethnic groups, we see that African Americans have higher cancer death rates among both men and women within this group. So as you can see here, African American men have higher death rates than any of the other male racial ethnic combinations represented by the red bars. And among African American women, we see 174.6 per 100,000, which is greater than any of the other racial ethnic groups. So I want you guys to remember that because that'll be important in a few minutes. This graph illustrates our cancer death rates by sex and race. So now kind of overlaying these two things from 1975 to 2009. African American men are represented by this red line. White men, the gold line, African American women, green, and white women, blue. So what you'll see is that, again, men are consistently higher than women, but African American men are experience higher death rates than white men. African American women, higher death rates than white women. So now we're gonna go through another set of slides that are gonna look very similar in terms of the figures, but I just want to point out that now we're looking at cancer incidence, which is different from cancer death. So we know that cancer incidence is just the diagnosis of a new cancer, and so we'll look at how those trend along with the death rates. So again, we see here greater incidence of cancer among men from 1975 through 2008. And when we focus on types of cancer among men during this time frame, you can again see some of the more common cancers listed here. So you'll notice that a lot of these things have been fairly flat for several decades. Lung cancer is almost kind of trending downward here. Colorectal cancer incidence is trending downward here. Maybe slight trends upward here, flat. But we notice that this line for prostate cancer is really kind of erratic. When looking at cancer incidence rates by type among women, we see that, of course, the highest incidence here has been breast cancer, but again, a fairly flat line over time, and for most other cancer types, incidence has been fairly stable over time as well. We notice slight decreases in colorectal cancer, and some of that is due to our ability to hopefully screen early, detect, and take procedures before it actually progresses to cancer. And looking at cancer incidence rates by race and ethnicity over time, again, we have men in the red bars, women in the blue bars. Men have higher incidence rates of cancer compared to women, but when we look by racial ethnic groups, I want to point out something here. So we see that Black males still have a higher incidence rate of cancer compared to every other racial ethnic group. But here we see that white women have higher incidence of cancer compared to other racial ethnic groups. So if you'll think back to the other slide that I told you to remember, we saw that African American women had higher death rates from cancer compared to other groups. And so it's interesting to think about. We have one group that has higher incidence rates, which would be white women, but another group that has higher death rates, which are Black women. And so as we talk more about disparities and think more about disparities, I want you to kind of keep that in the back of your mind. And this kind of just probably reiterates what I just said, looking at rates and trends over time. We see little spikes here among the men, which is probably related to prostate cancer, but things have been fairly flat and consistent over time, and you can kind of see the order of incidence. And so the next few slides will just kind of look at the probability of developing cancer and survival rates. So this is for men, among men in America. We would expect that a little bit less than 1 in 2 men have a lifetime probability of developing cancer. And it kind of breaks it down into the different types and shows risk level here. For women, that number is a little bit closer to 1 in 3. And women are going to be at greater risk of developing breast cancer than any of the other cancers listed here. And so here we have just a graph describing the 5-year relative cancer survival rates by race. As you can see, when we kind of lump in all cancer sites together, whites, I think this includes males and females. So whites have a 66% 5-year cancer survival rate compared to blacks who have a 58% 5-year survival rate. So there's an absolute difference there of about 8%. If we look at different cancer sites, we see that basically the survival rate among whites for all cancers is higher than that of African Americans. And just kind of looking at these absolute differences over here, you can see that for several of these cancers, there's more than a 10% difference. So there's something going on there. Again, that's this disparity that we're talking about, and just kind of keep that in mind as we continue through. And so finally, just kind of looking at the big picture, looking at a map here, this really illustrates the unequal burden of cancer throughout the US. So this map shows cancer mortality rates for all sites, all races across the US. The legend kind of shows where the hot spots are, or the incidence or mortality in different areas. So as you can see, the highest mortality rates are represented by the red colored states. And as you can see, that's really kind of clustered right here in the Southeast, Deep South kind of states, Alabama, Mississippi, Tennessee, Louisiana, so on and so forth. So with that said, is it possible to change this? Is it possible to reduce or eliminate deaths from cancer? There's lots that need to be done, but we, as cancer researchers, have kind of started thinking about priority areas of where we can have the greatest impact. And so I'll go through a few of those things. And we think one very important thing is age-appropriate screening. That's one of the easiest and most cost-efficient ways to start to think about reducing or eliminating death from cancer. Early detection is key for all treatments, and we know now that even for cervical and colorectal cancer, early detection can lead to prevention of development into cancer. So age-appropriate screening is very important. Tobacco control is an area where we think we can get a lot of bang for our bucks. We all know that tobacco is a carcinogen, so that goes for chewing tobacco, cigarettes, cigars, the whole spectrum. And so the more that we can convince people not to use those things, we anticipate a reduction in cancer. Healthy eating and physical activity. So there is a pretty solid body of literature at this point that has linked obesity to several cancers. And so if we can encourage and promote healthy eating and physical activity, that's going to help with weight control and weight management, hopefully help to mitigate or reverse the obesity epidemic, because some data projects that obesity is contributing to as much cancer now as tobacco once did. So addressing the obesity epidemic is going to be a very important part of cancer control. And I'd also like to throw in that we also know that physical activity is a good thing independent of weight loss. So as much as we can do to promote people to be physically active, even if they are not trying to lose weight or not successfully losing weight, physical activity is still a good thing for cancer prevention and definitely control. And then the final thing is access to quality care. I mean, we know that if there is a diagnosis of cancer, those who can get appropriate treatment have a much better chance of being survivors. This is just a schematic of the interplay, and it's a very complex interplay of a lot of economic, social, cultural factors that influence cancer disparities. And that's across the entire spectrum, from prevention through diagnosis, treatment, survivorship, so on and so forth. We have a solid body of evidence showing that education, poverty, things of that nature contribute to not only cancer disparities, but health disparities in general. There are also some cultural things in terms of beliefs that may contribute to the health care that people choose to access. It's just a very complex and multifactorial issue. And so we're going to kind of talk about some of those things and try to tease some of it apart. And so now I will kind of shift gears and talk about UAB's effort to eliminate cancer disparities. And much of this work is led by the UAB Comprehensive Cancer Center. You may or may not know that it's the only comprehensive cancer center in the state of Alabama. For it to be designated as a comprehensive cancer center, it must define the region it serves, address the highest cancers of highest incidence, morbidity, and mortality, and also address the needs of the populations with disproportionate cancer incidence and mortality. The director of the Cancer Center is Dr. Ed Partridge, and he's also the principal investigator of several of the projects that I will talk about in the next few minutes. So again, we're back to this map, and this is actually a map showing the distribution of African Americans in the United States. As you can see, red is more. Red is always more for some reason. But as you can see, majority of the African American population is clustered right here in the Southeast. And if I were really techie, I would have done all of these map overlays to show you how many other things cluster right here in the Southeast if we were to overlay maps. So if we think about poverty, it's clustered largely in the Southeast. If we think about obesity, it's clustered largely in the Southeast. If we think about other morbidities and mortalities, it's clustered right here in the Southeast. And so thinking about the African American population being clustered right here in the Southeast, I won't go into a huge history lesson, but if you just think about the history of African Americans in the US and a little bit of geography, it's not hard to figure out why that is. With the transatlantic slave trade, Africans were basically transported across the Atlantic Ocean to the southeast of the United States, where they lived as slaves for about 400 years. Slavery was eventually and fortunately abolished, but during that time, living conditions were poor, nutrition was poor, healthcare was poor, and so as you can imagine, that can kind of set kind of a bad thing in motion, and that, you know, the trajectory may be a little bit challenging to address. Even moving up, you know, to things that are relatively more current, these are just some pictures from the 1960s, where the civil rights movement was a very important thing to try to help minority groups in the United States to have equal rights. But, you know, there are still some challenges there in terms of actually establishing equality, both for economics, for healthcare, for living conditions, et cetera. And that also led to issues with trust and connecting with the healthcare sector, medical providers, things of that nature. And so I use that to kind of frame the historical context of some of the things that we're dealing with now. And so keeping that in mind, UAB, led by Dr. Partridge, established the Deep South Network for Cancer Control a little bit over 15 years ago. And the goal of Deep South Network is to eliminate or reduce cancer health disparities in the Southeast region, and particularly in Alabama and Mississippi, where the counties affiliated with Deep South Network are. I also have Claudia Hardy's name up here. She's been the program manager for Deep South Network since inception. And I would be remiss if I did not acknowledge her, because she has made this thing work. So again, here, it's just a map of Alabama and Mississippi. And highlighted here, we have counties that are considered our Alabama Black Belt counties, along with Jefferson County, which is really not a Black Belt county, but we wanted to have some urban population represented here as well. And then we have our Mississippi Delta counties as well. And for the record, this is so off topic. I was not around as a scientist when this started in 2000. That would make me feel so much older. So, so I'm just one of the people who was able to come in the last several years and benefit from a lot of hard work that happened before I got here, just for the record. And so just to give you a little bit of a sense of the conditions in the counties that this work has happened. Income in the Alabama Black Belt, annual income, $12,000 a year. In the Delta, about the same. Poverty levels, as you can see, a third or more of these individuals are living in poverty. And as you can see, there's also a high percentage of African Americans in each of these counties. And they're fairly comparable from the Mississippi counties to the Alabama counties. Here are just some more pictures to give you a little bit more context. Very limited options for restaurants for dining, very limited options for grocery shopping, very limited options for healthcare. Some of these people have to drive an hour to get to a grocery store or a Walmart. They have to drive an hour or more to get to a hospital or a physician. So just, again, context and keeping these things in mind. These are actual homes. People live here. So if you just think about it, it's easy for us to kind of be here and think about, well, people need to do this and people need to do that and come to the doctor and eat this and don't do that. But if people are living here and trying to figure out, you know, how they're going to survive to the next day, then healthcare might not be their number one priority. These are just other pictures from the Alabama Black Belt. So again, very rural. Oftentimes, a lot of travel is required to get basic things. One thing that was so eye-opening to me that I learned in working with these counties is, so I don't like to drive in the rain here in Birmingham. I don't like to drive in the rain anywhere. But I learned that when it rains there, in many areas, it's not about the fact that they don't like to drive in the rain. It's they can't go anywhere in the rain because the roads are not paved. So this isn't a great picture of that, but the roads are not paved. They're dirt roads that are washed out, so they can't go to certain places during the rain. So these are the kinds of things that we often don't think about, but play a major role in these people's day-to-day experience. So the theoretical framework that underpinned all of the activities for the Deep South Network includes a coalition development model, so efficient and effective ways to develop coalitions and partnerships. It included community empowerment, so empowering the community to improve their health, take control of their health, but not just their health, issues that are important to their communities that may not have anything to do with health, but just community improvement overall. And kind of the cornerstone or the real gem of Deep South Network is this community health advisor model. So community health advisors, we like to kind of call them our natural helpers. So we all know those people who are always wanting to be involved, always wanting to do something, really recognized as community leaders with or without an official title in a leadership role. So a lot of the work went into identifying these natural helpers and engaging them in becoming a part of this Deep South Network. We had a number of trained volunteers. These people are coordinated on a daily basis by paid staff. And the work of the community health advisors, and we call them CHAWs, so if you hear me say CHAWs, it's the same thing. The work of the CHAWs includes conducting cancer awareness activities, promoting cancer screening, advocating for minority health issues, and then eventually they even transitioned into serving as research partners, which was an amazing process. They were critical for our research needs in terms of assessing what the community needs. They provided peer support to one another. They provided technical assistance to us because they are the experts in their communities. I mean, we may be the experts at the research or the science, but they're the experts in their communities and conditions. And they also were critical in helping to actually implement some of our evidence-based research interventions. So the CHAWs, it was really a commitment. You know, they did 16 weeks of training. A lot of that was focused on cancer education, but we also integrated just training in core leadership skills so that they could really take hold of being those community leaders and move the work forward. There was a graduation ceremony at the end, and then they actually kind of maintained their own cohort and had monthly meetings and, you know, planned events and all kinds of things. And so in just thinking about establishing this partnership over a 15-year period, there were over 1,200 CHARPs or CHAWs trained across the state. And this is a volunteer thing. This was not a paid position. We had paid staff to coordinate them. We had over 250 local partners to be a part of it. Currently, 300 CHARPs are still active with our work. County coordinators were included. At one time, there was a huge central staff here at UAB that kind of oversaw and headquartered all of these things. It also included program directors and investigators. And so, if I start talking about things kind of in past tense, we are slowly winding down the official funding for this project, so we will keep the network and infrastructure in place, but the current project, as it has been over the past 15 years, is kind of coming to its closing phases. So the target cancers of the Deep South Network include breast, cervix, and colorectal cancer. And activities were generally lumped into two categories. There were the outreach counties and the research counties. And the goal of the outreach counties has really just been to reach the previously unreached, to provide some cancer education to those who may not have had any, to share screening recommendations, provide support, things of that nature. And then the research counties actually participated in a full-fledged, all-out cluster randomized controlled trial that you'll hear about in just a moment. And so these are just some pictures of some of the people that have been a part of this and some of the things that they've done. Deep South Network has been very active in health fairs in their local communities. They formed walking groups. They definitely have a number of church-related activities. So you have Pink Sunday, you have Blue Sunday, you have Sundays just to do cancer awareness and health education and promotion that coincide with some of the cancers that we are targeting. Here there are more pictures. So this is a group that are exercising together. Some of them are our community health advisors. Others are people who they have brought in from their community to come in and work out with them and try to increase physical activity. You have one of our CHAs here doing a cancer education seminar. And I really love these pictures at the bottom because these are people in their local communities actually doing assessment of the nutrition and physical activity environment in their own communities. So we provided them with some validated tools and training on how to use these instruments, and we sent them out in their own communities to find out, what do you have in your grocery stores? What are the prices? Do people have places to walk? Do children have places to play? And this is important because it'll help to inform future research efforts that we may have, and it also may play a vital role in future policy things in terms of resources and funding that may become available for those communities. And the nice thing is that they are doing it themselves. It's like they're taking ownership of this. So earlier on, a lot of Deep South Network activities were really focused on increasing age-appropriate screening, because again, that's one of those, easy, kind of low-hanging fruit things that we can all try to do. And so I have just a couple of slides to try to reflect what we feel is some of the impact of the work of the Deep South Network. It's probably not the best way to look at this data, but we do think that it is a fair representation of the effects of some of our work. So what we have here are hazard ratios comparing basically risk of death from cervical cancer, comparing our Deep South Network counties to non-Deep South Network counties. And so we have data from these counties preceding the inception of the Deep South Network project, and we see that our Deep South Network counties have a hazard ratio of 2, meaning there's an increased risk of death from colorectal cancer for residents in this county. Deep South Network did work from 2000 to 2005 to try to promote age-appropriate screening, and looking at data following this time period, you actually see a reverse in the hazard ratio, such that people living in Deep South Network counties did better than people who were not in Deep South Network counties. So again, it's not the most sophisticated way to look at this data. In hindsight, we probably could have done some things a little bit differently, but also keeping in mind that at the time, research was not the focus, it was just outreach. So we kind of did the best that we could. Here's another figure that kind of displays what we think is some of the impact of work of the Deep South Network. So if we look back here in 1997-98, mammography screening, and this is among women with Medicaid. So we're eliminating insurance or access to health care as a possible contributor. For white women, we see still 16% more were utilizing age-appropriate mammography screening or screening for breast cancer in 97-98. We fast forward 10 years, this is post-implementation of Deep South Network, and that gap has essentially closed. And over here, it's, it's not necessarily a significant difference, but Black women are even kind of creeping to greater numbers than white women. So this is something that Deep South Network takes a great deal of pride in. We're excited that we've been able to close this gap. But the downside is that we see that for both groups, this bar is still less than 60%. So probably 56 or 58% of eligible women are being screened. That number needs to be closer to like 90 or greater. So still work to be done, but success has been achieved. Now, in terms of nutrition and physical activity efforts of Deep South Network, it goes back to that randomized controlled trial that has been the major effort of the network for the past 5 years. And the goal of this trial was to reduce cancer disparities by helping African American women, and by extension, their families, to achieve and maintain a healthy weight. So we engaged our community health advisors to become interventionists of sorts. We trained them on how to implement an evidence-based behavioral weight loss intervention and how to deliver that to study participants. So the CHODs were the interventionists. These interventions took place in the local community. We did not have behaviorists or nutritionists or anyone go out. These were things that they did on their own in their local communities. So we had 4 counties that received this evidence-based intervention alone. The other group not only received this evidence-based weight control intervention, but we also provided the counties with seed money to utilize how they would like to implement community strategies for health promotion or for healthy living. So some communities wanted to establish a community garden. Others used it to try to clean up or improve walking trails, fitness classes, fruit and vegetable vouchers. It was up to them. They basically just had to submit proposals to our investigative team. They were evaluated and awarded as such. And so I'll talk a little bit about some of the interim outcomes from that project. We're currently in the process of really finalizing the data analysis on the primary outcomes from the study. But a few things that we're really excited about. Number one is just the participant enrollment and engagement. So again, keep in mind, we have this thing in mind called those who have been unreached or the unreachable population. But just through this research effort, our local field staff recruited nearly 1,000 women to screen for this study. So these are 1,000 women that we came in contact with, that we were actually able to touch, and even if they didn't enroll in the study later on, we were able to impart some education for them during that time. And as a part of a lot of the screening processes, they learned about their health. Part of that was, to check their blood glucose or blood pressure or things of that nature. So just access to health information that they may not otherwise have received. We ultimately enrolled 409 women. The goal for the study was 400, so we were very happy to exceed that. At 6 months, our retention for the study was 95%. We think that the community health advisors played a huge role because these are people who are in their community, who are trusted, who are respected, who are known. They see one another in the grocery store. You need to be at the study thing. Right. So peer pressure, right. Exactly. So, we can't take much credit for it here in the home office. I really do think it goes to the credit of the community health advisors. And that's why, it's not the right model for everything, but oftentimes we're trying to reach these underserved populations, it really can be a really nice model. So we collected data on a ton of behavioral measures. We also collected body measurements as well as blood samples so that we can look at metabolic markers. And as I said, all of that data is pretty close to being finally analyzed, but I'm actually not going to go into it today. But just anecdotally, we kind of know our participants who were our biggest losers, and from what we know on their open-ended surveys and conversations with them, they just really, changed the diet, engaged the social support of friends and family, got moving, and some of the things that we already know can lead to healthier weights. Some of the primary challenges that we ran into with this program was just so many comorbid conditions among individuals in this population. And in terms of actually implementing the research project, of course, we had to have some exclusion criteria for a number of reasons. Since then, though, we have had some conversations as investigators as well as talked to some of our community leaders to talk about what we can do in the future to engage some of these people in some of our efforts as well, because, kind of if you think about it, these may be the people who can benefit the most from what we're doing. But unfortunately, due to kind of rigid research criteria, we're not able to participate in this study. But I just want you to know that the work that Deep South Network has done has really just kind of developed legs and arms of its own. So there are a ton of projects in addition to the weight loss program that I just described. There's been a new weight loss program for cancer survivors, other programs for trying to eliminate health disparities among children. We want to promote and increase screening, and just, the list goes on and on. So like I said, it's not the right model for everything, but for some of the community-based kinds of things that we want to do in reaching these really underserved communities who are the ones who are bearing a disproportionate burden of cancer and other morbidities, this model has worked very nicely. So we've learned a lot of lessons. One thing that is very encouraging is that we already know a lot about how to reduce cancer disparities and reduce death from cancer. And the things are not really that complicated. Age-appropriate screening, you'll hear me say it a million times, diet and physical activity, and tobacco control. They're not that complicated. It's just actually getting the information to people and getting people to do it. And so even with not having another discovery related to cancer, if we could successfully deploy these things, we could still lead to tremendous improvement in the morbidity and mortality rates that we currently have. We think that efficiency is very important, so trying to focus resources on the populations that are most at risk. We are definitely excited about the Affordable Care Act because we hope that that will eliminate this access barrier so that everyone can access quality health care. And another thing that's really exciting is that these communities are very, very eager to engage. So one common theme that we have seen across not only the studies that I presented today, but many of the studies that we're doing in these rural counties is they want something, they want help, they want to participate, they just need to be invited and asked.